Okay, the nurse recognizes which finding as the most concerning in a patient with suspected urinary retention. Most concerning. Urinary retention. Avoiding 15 mils every 2 hours. I mean, you should be at 60, but it's fine. No output for 8 hours with bladder distension. Not going very much. Go and pee twice at night. Clearly, 8 hours. That's your threshold. Which UA result requires immediate follow-up. Specific gravity of 1.02, pH of 6, presence of nitrates and white blood cells. Ooh, white blood cell enzymes. And clear yellow pee. Clearly, you don't want to have nitrates and white blood cells in your pee. The nurse is teaching a client with stress incontinence about management, which statement indicates understanding. Limit fluids to avoid accidents. I'll perform Kegels several times a day. I should avoid walking to the bathroom often. I should wear tight undergarments for support. Okay. Stress incontinence. They're stressed out and I guess they have to pee, or stress, like physical stress, maybe? I think it's physical stress. So, drink water. Usually 99% of the time, the answer is never going to be don't drink water. Perform Kegels. That's a pretty good option. Avoid walking to the bathroom often. Don't hold it. And if you're a girl, they say don't wear tight underwear. I say as I wear thongs every single day and will never give up my thongs. But clearly it's Kegels. The nurse suspects a urinary tract infection in an older adult. Come on. UTI. Older adult. What are we doing here? Confusion. Which finding is consistent with polyuria? With polyuria. Too much pee. You're peeing a lot. Urine output less than 400 mils a day? No. Urine output exceeding 2,500 mils a day? Yeah. And I mean, the other two are just dumb. They're literally just knowledge. Do you know what polyuria is? When assessing for urinary retention, which is the most appropriate, inspect the flank for bruising, palpate and percuss the bladder, assess the costiovertebral for tenderness, note the urine color and clarity only. I mean, you're looking for retention, so you don't have urine to look at. The costiovertebrae, we'll get to a question with that later. Flank, that doesn't even make sense. So yes, clearly you're going to see, is the bladder distended? What is the nursing diagnosis is most appropriate for a patient with incontinence and skin irritation? We know this. I'm not reading this. I'm not even entertaining that question. It's impaired skin integrity. Which intervention should the nurse include to prevent infection in a patient with an indwelling catheter? Disconnect the tubing for ambulation, maintain a closed drainage system, cleanse the meatus with antiseptic hourly, keep the drainage bag above the bladder. Clearly, close the system. All the other ones, you're gonna get, like, that's just too much. You're not cleaning every hour. You're not putting it above the bladder. Why, just don't take that shit out. I don't want to get that shit put back in me. If you're taking it out, you're taking it out. You're not putting it back in. The nurse reviews a 24-hour urine collection. I mean, my god, how many times can we get this fucking question? Discard the first. And then it starts after. Painful urination. Dysuria, auria, polyuria, oliguria. What is it? Oliguria, what is that? Yes. Decreased urine output. Polyuria, what is that? Yes, increased urine output. Anuria. Auria. Yes, no urine output. Dysuria, painful output, or painful urination, yes. Nurse notes cloudy urine with a strong odor. What is the nurse's first action? Encourage oral fluids, notify the provider, assess for fever and flank pain, document normal findings. Yes, fever and flank pain. You want to know, is this UTI? Is this an upper UTI? Is this a middle UTI? Figure it out first. Assess, assess is always the first step, actually. So, which diagnosis identifies kidney stones? Kidney stones, where do you think you get it? A urinalysis, a UA test, you pee in a cup and they tell you if you have kidney stones? A cystoscopy, they go into you and look. A bladder scan, they look in your bladder. Or a kidney, urinary, bladder x-ray. Okay, clearly the x-ray. It's in the name, kidney, urinary, bladder. Which factor increases the risk of urinary tract infection in women? Select all apply. Shorter urethra, true or false? True. Postmenopausal estrogen loss, true or false? True. Frequent catheters, true. Fluid intake of over 3 liters a day, false. Going pee after sex, false. A, B, C. Which assessment should the nurse perform to evaluate kidney tenderness? Oh, okay. Palpate the suprapubic area, that's where the bladder is. Percuss the costovertebral angles. Inspect the bladder for distension, that's the P, that's the bladder. Palpate over the iliac crest, that's on your hips. Where are your kidneys? Yeah, they're in your mid-back. So the only one of these that even has a spot in the back, I would say that's where you would feel your kidneys, that they were tender. Nurse caring for a patient with oliguria expects which finding? Oliguria, figure out what that is. Okay. Output less than 30 mils an hour. Greater than 2 liters a day. Can't pee. Frequently peeing, but not much. Okay. This is one of those pick the most right questions, because technically this is right and this is right. This doesn't give you an amount. What is small? That's subjective. This is objective. A is right. Less than 30 mils an hour. Which nursing intervention is appropriate for a patient with nocturia? What is that? Yes, nighttime peeing. Restrict evening fluids and provide a nightlight. Increase fluids before bedtime. Place a commode far from the bedside for privacy. Encourage diuretics at night. Okay, you don't take diuretics at night. Why would you put the toilet far away from the bed? Why are you giving them fluids before bed? Yes, take away the fluids. Give them a nightlight so they don't fall. Not some dumbass who's just trying to get up. Can't see. Okay, pyridium. What is that? It's azo. What does it do? Yep, turns your pee orange. Okay, which finding would indicate pyrrolone nephritis? Do you see that word in there? That's kidney. Nephritis. And other than cystitis. That's bladder inflammation. Just learn that. I can't say it. Suprapubic pain only. That's bladder. Low back pain, flank pain with fever and chills. That one. Remember that one. Cloudy urine without a fever. I mean, I guess. Dysuria and urgency. Okay. These 3 things all can indicate both. But we want just this. So is a swollen bladder probably going to give you low back pain and side pain with fever and chills? No. But your kidneys will. Kidneys are the worst when you get them fucked up. Which client report requires immediate action by the nurse? Burning with urination, frequency at night, inability to void with severe low abdominal pain, or voiding small amounts frequently. Clearly, the person who is retaining their urine and it hurts. Which finding suggests successful treatment of a UTI? Persistent urgency, negative nitrates on the UA, pH of 8.5, cloudy appearance. Okay. It's not pH. You don't want cloudy pee. I feel like my pee's cloudy all the time, though. Or you want them to always go pee. Clearly, you want to be negative on nitrates on the UA. Okay, last one. We're almost freaking done till tomorrow morning. Client with COPD is seated upright, leaning forward with forearms on the bedside table, using accessory neck muscles to breathe. What is the priority action? Encourage the patient to lie in a supine position. Coach pursed breathing during exhalation. Apply oxygen mask to maintain SpO2. Take a rapid, shallow breath to conserve energy. That one doesn't even make fucking sense. Pursed lips, just associate pursed lips, COPD. I'm pretty sure that's why they're called pink puffers, because they burst their lips. During posterior lung auscultation, The nurse hears a high-pitched musical sound primarily on expiration. The client is reporting chest tightness. What is the best interpretation? Coarse crackles from fluid, sibilant wheezes from narrowed airways, pleural friction rub, or vesicular breath sounds. That's not even where over the trachea. See, that's just a knowledge base. That's not where that is at all. It's sibilant wheezing. Expiration, you're breathing out, you're hearing a high-pitched sound. That is a wheeze. Which client finding requires immediate follow-up during respiratory assessment? Respiratory rate of 26, speaking full sentences. Use of accessory muscles at rest. Pursed lips breathing during ambulation. Barrel chest, APT. Use of accessory muscles. You literally never want that. That's bad. You're teaching the student the correct technique for lung auscultation. Which statement indicates a need for further teaching? What is this question asking? It's asking which one of these is wrong. Which one? Who is saying? What is she saying? And what is wrong? What are you gonna be like? Whoa, you didn't listen to shit I just said. I'll listen with the diaphragm over bare skin. I'll compare side to side at each level. I'll only listen to one full inspiration to each spot to save time. I'll listen and instruct the patient to breathe slowly through the mouth. Clearly, you want to listen to an expiration and inspiration in each spot. An older adult reports paralytic pleural pain with deep breathing. On auscultation, you hear a harsh, grating, and all of a sudden, I hear this irritating, grating sound. That's a TikTok sound. You hear a harsh, grating sound that persists when the patient holds their breath. What should you expect first? Fine crackles. No, that's on inhale. Sonorous wheeze. That's on exhale. So you're not breathing. Now you're between these two friction rubs. But what is it? Okay. Well, one of these is in our vocabulary, but one of them's not. But we can also figure out, if we didn't know, we could figure it out. What is the pleura? What is the pericardium? The patient's holding their breath. The pleura is in the lungs. If the lungs aren't moving, how is it possible that there could still be a sound? It's the pericardium. It is the thing that wraps around the heart. It's rubbing up against something. While inspecting a client's thorax, you note a barrel chest and a costal angle of more than 90. What additional finding would you expect with chronic hyperinflation? Decreased diaphragmatic exertion and hyperresonance? Increased tactile fermentus and dull to percussion? Asymmetric chest rise to lobar collapse? Whispered pectorally over the peripheral lung field? I don't know what the fuck I just said. Okay. Barrel chest, 90 degrees, more than 90 degrees. This is the only one where you hear hyperresonance. I don't know what decreased. It's this one. It is this one. I'm so tired. I can't. Okay? I can't. Client with dyspnea is sitting upright and anxious. Which sequence best reflects a focused respiratory assessment? Focused respiratory assessment. They are sitting upright, they're short of breath, and they're anxious. What are you going to do? This person is anxious. Is there something wrong with them, or are they just having anxiety? Are you going to listen to the lungs, look at the chest, and then palpate the thorax? Look at the way that they're breathing? Listen to the lungs, and then put a pulse ox on them? Listen for crepitus, obtain a health history, and then listen to the lungs. Percuss the lung fields, inspect, and then assess capillary refill. This person is short of breath, and they're anxious. You don't care about the cap refill. And you're also gonna assess first, right? Your inspect is probably always gonna be first. So clearly you're gonna look at how they're breathing, listen to their breathing, and then you're gonna say, okay, well that all sounds good, but this person really is can't breathe, so let's see, are they oxygenating? I can't say that word. Nurse suspects pneumonia in the right lower lobe. I feel like we've done this question a lot. So fever, tachypnea, yes or no? Yes. Crackles over the right lobe, yes or no? Yes. Decreased breath sounds, yes or no? Yes. Symmetric chest without pain, yes or no? Yes. Sibilant wheeze during inhale. Well, that's during exhale, so no. The client with sudden subcutaneous crepitus around chest tube sites asks what's it mean, which is the best response. We've done this. Yes, it's trapped air leaking into tissues, which finding indicates effective use of tripod positioning in acute respiratory distress. That's how my dad died. ARDS syndrome, acute respiratory distress syndrome. Effective use of tripod positioning. So this is a nurse saying, hey, go in this position. Increased use of muscles, that's accessory muscles. Decreased work of breathing with improved chest expansion. Reduced diaphragmatic exertion. Increased accessory muscle fatigue. Take these two out. IND. Why would we want to put them in a position that's going to increase their accessory muscles? Now we're between these two. And this is just knowledge based. It's decreased work of breathing with improved chest expansion. I can't give you anything more than that. I'm too tired. Actually, yes, I will. Basically, let's just Google this. Do you want it to be lower? No. Okay. I get it. So, bad thing, bad thing, bad thing. Only one good thing. After instructing a client with diaphragmatic and pursed-lipped breathing, which outcome shows effective learning, increased respiratory rate, and short exhales, the client reports less shortness of breath and lengthens their exhales. SpO2 drops slightly, but their work of breathing is unchanged. Client switches to mouth to nose breathing. Okay, well, that's not what this is. This is breathing in, and when you breathe out, your lips are pursed, and you're going like giving birth. So, effective learning. Client reports. Effective learning. Client reports. These are not really client reports, but also it is this one. Less shortness of breath and more longer exhales. Because you're teaching them how to breathe. During inspection, the nurse notes sternal retractions and intercostal muscles used. What is the priority intervention? Encouraged coughing. Notify the provider and prepare for escalation of O2. Place the client supine. No. Limit activity and reassess in 2 hours. Okay, well, this seems like it's probably an emergency. So, not 2 hours, not supine. So, now we're between these two. Should we cough? Do you think we should cough? Do you think coughing's going to fix this? No. You're going to need a little bit more help. Okay. Shane Stokes. What is Shane Stokes? Shane Stokes is even, not breathing. Even, not breathing. So, apnea pauses. Even up and down with a pause. Even up and down with a pause. Irregular respirations with period of apnea. That's Biot's. It's Biot's. Rapid, deep, labored breathing throughout. Okay, I told this one to Jasha. This is Cosmos. Cosmos ends in K. Do you know what else ends in K? Dick. Rapid, deep, labored breathing. When you're getting fucked, it's rapid. It's deep. Deep in there. And you're labored breathing throughout. I'm not doing that. But it's deep. Okay? Then you have shallow rapid breathing. That is shallow hyperventilation. Right? Hold on. Let me double check. Where the hell? Yeah, deep. Okay. This is tachypnea. Hypoventilation is deep, or hyperventilation is deep. Tachypnea is shallow. In older adults, which age-related respiratory change is most expected? Marked asymmetry, kyphosis with decreased but symmetric expansion, hyperactive cough, increased vital capacity. Vital capacity is like how much I think you can breathe in and hold. Hyperactive cough reflex, I mean, maybe. Marked asymmetry in the chest. You ever seen an old person? They're not really lopsided unless they've like smoked their whole life. And then kyphosis with decreased but symmetric expansion. We know kyphosis is an expected change, and we know that you probably cannot expand the way that you used to, but you're probably still symmetric. 5 more. Which instruction is correct when when auscultating posterior lungs? Start at the bases, move up, go side to side or without comparing. Ask the patient to breathe slowly through the mouth at each spot. Use the bell to pick up high-pitched crackles. Listen to the scapulae to assess apices. What? But yeah, it's the mouth. You go to the doctor and they say, okay, in through your mouth and out through your mouth or whatever. They say in and out. Breathe slow. Deep breath. A client suspected for pulmonary edema is assessed. What finding supports this diagnosis? Sonorous wheezing that clears with coughing. Fine crackles at bases of lungs that worsen with inspiration. Hyperresonance. Nope. And then pleural friction rub. Okay. Pulmonary edema. Pleural friction rub. What is that? That's plural. That is the pleura. So it's not pulmonary edema. It's the pleura. Hyperresonance. No. Fine crackles at the bases of lung. Well, let's think about this. Is fluid heavy? Is fluid heavier than air? I would think so. So I would say, yeah, it's probably the fluid in the lungs. The nurse is preparing to auscultate the lateral lung fields, which let me hold on. I'm breaking the fourth wall because I need to. I wish that my freaking numbers carried over to my laptop. Okay. The nurse is preparing to auscultate lateral lung fields, which landmarks and approach are correct. Mid-clavicular lines, listen to the sternum only. Use anterior, mid, and posterior axillary lines, compare bilaterally. Listen to the anterior axillary line for vesicular sounds. Skip lateral fields if the posterior is clear. Obviously, we've done this. We've been tested on this. Anterior, mid, and post. Which client report requires an urgent respiratory assessment? STA, SATA, true or false? I can only breathe comfortably when I sit upright. True. My chest feels tight, and I'm wheezing. True. I cough clear sputting, but only in the morning. False. I get short of breath when I'm walking to the bathroom. True. I feel fine when I'm laying flat, and I don't get winded. False. The student percusses the right lobe posterior chest of a client with suspected pleural effusion, which note is consistent with this condition. Pleural effusion, what does it sound like? That's right, it's dull. The nurse is asking which nurse action best reduces the risk of fatigue and hypoxemia when auscultating a shortness of breath client. This is low oxygen in the blood. This is fatigue. You know, you know how it goes. So, clearly, read them. Take rapid deep breaths only through the nose. Allow them to rest. Complete them supine. Or complete the entire exam without interruptions. Obviously, give them a break. Let them chill. Okay, we're done. That's just the answers to this.